So good morning one and all, and it's a privileged moment here to be once more in the same IC, and thanks to Dr. Naresh and the AIOC Scientific Committee for giving this opportunity to me to participate in this discourse. So I just be highlighting some practical points for ocular trauma management, especially the window of the eye cornea. So as cornea, as you know, it's a refractive structure. So the outcome may not be predictable as you do it, even if your surgery and is par excellence. So I have no financial disclosure in this presentation. So open glove injury, as already described, as for definition, is a full thickness defect in the cornea, sclera, or both. So it is the leading cause of ocular morbidity in the children and the young adults. 80% of the people have worse presentation during the presentation, the visual acuity is worse, and only 10% have a greater visual acuity than 20/40 after final repair and done. So corneal lacerations, corneoscleral lacerations, scleral lacerations, or occult globe rupture can be the different way of manifestation of the ocular injury. So simple classification to start with is the closed globe injury and open globe injury, and the closed globe injury can be contusion or lamellar lacerations, and the open globe injury lacerations or rupture. The lacerations can be penetrating intraocular foreign body or with perforation. So the history is more important for this type of injury case. You need to know about the mechanism of injury, what hit the eye, and what was he doing during that activity, how did he get it, what was it, is a flying object or was it with a vegetable matter. So the management starts with the investigations. The plain X-ray or radiograph will have his own importance. Ultrasonography, CT or MRI also play a different role in the time of need. So as per plain radiograph or X-ray, you should have a PA view which will show you the intraocular or the intraorbital foreign body here, and then it also shows you the orbital fracture, and also it is badly needed and absolutely needed for medical legal aspect. Ultrasonography will show you the vitreous hemorrhage, retinal detachment, choroidal detachment, or a radio foreign body or radiolation foreign body with or without vitritis or endophthalmitis. CT has got its own advantages, and it should be done in case suppose you cannot multiple injuries, accident injuries where whole body is affected. It is really helpful, and suppose you suspect any metallic foreign body, then it has got a better role. So it starts with the medical management. Tetanus toxoid should be given as a prophylaxis, and systemic antibiotic, whether orally or intravenously, is a choice. So some cases, although they present to us injury, do not require any medical or surgical treatment. So they are usually suffice for us to do a medical management alone. So length of the lacerations, if it is small and less than 2 millimeter, and no intraocular, no intraocular or no foreign body in the wound itself, or no other ocular structure is involved, it is a self-sealed and positive sealed test, and can be only seen when there is a pressure. So these are the cases which you need not go for surgery, surgical repair immediately. You should go for the conservative management, and for but there is an exception to it. Children are uncooperative patients or mentally retarded or challenged patients are need not be taken any risk. So primary wound repair is done in case of full thickness tear with Siddle's positive or with tissue incarceration, corneal, only corneal tear with iris or sclerocorneal tear, or this type of total rupture, and timing of the surgery also a little bit controversial, but so far as the rupture or laceration of the globe is concerned, it has to be operated immediately, and presence of intraocular foreign body should also be worrisome, and it should be taken as early as possible. So there are two literatures which have elaborately published that risk of endophthalmitis does not significantly increase in the first 24 hours to 36 hours. If the if there is done, it is late by up to 36 hours. Similarly, the visual acuity is not that much affected if it is delayed by or up to 36 hours. So, so far we have to have a proper goal of the repair. So repair of the globe to maintain the integrity, to normal anatomical clarity or appositions, and to maintain or the have least complication during the initial surgery or subsequent follow-up, and to restore the vision as far as possible. So counseling plays an important role here. So the selection of suture needle is prime importance. Micro needles is like reverse cutting spatulated needle with tenon linon sutures are of prime importance for corneal or scleral sutures, and vehicle sutures has to be given for conjunctival tear. So knots are usually 311 and it should be buried away from the wound, and it should not be on the surface. And the tear repair, the depth is always 85 to 90%, and it has to be almost like 1.5 to 2 millimeter, almost like 1 millimeter either side, if it is a vertical or perpendicular cut. If this is not the case, and then you have to have a different repair principles. So principle like you have to identify the limbus, you have to identify the anatomical landmarks, you have to identify the angles which will help you to align. Just like this case, first sutures will be, this is not even involving the limbus, but anyhow your the first sutures will be at the angles. This is the angles. So angles are suture first, suture second, then edges, and then bisect it and do it. Bisect it exactly and do it. So the zone of compression is equally important because the small sutures produce a less zone, larger sutures have maximum zone, and medium sutures have also equal zone. So the distance, height of the suture and the distance, interdistance between the sutures is important to have a ideal tightness and the apposition. So oblique lacerations, you can see here it little bit differs. So on the oblique lacerations, so the primary aim is to close the posterior wall properly than the anterior surface. So if you do wrong suturing, what can have the shallow sutures will have a either overriding or will have a wound gap of internal lip. Suppose you get a suture which is involving tear is involving the center also, then the principle starts with suturing at the longer sutures at the periphery to stiffen the central axis, and small sutures at the center to flatten the central axis. So the special situation like this, like sclerocorneal tears or the lacerations involving the pupillary axis, zigzag tears, stellate tears, lacerations with iris prolapse, limbal tear and sconical tear with cataract has to be dealt in a special way. So first number we will go for the sclerocorneal tear like this. So first principle is that you need to oppose the limbus first, and then go for the cornea, and then start suturing the sclera posteriorly. And need not go to the equator. If there is more than 1/3 of this or more than half of the suture is you have done, then if still you think it is there, then you need not bother, you can leave it like that. And so lacerations involving visual axis should be, no touch technique should be done, and you should, I have already told you, we have to have a place the two sides on the either axis of the visual axis, either side of the visual axis, and then small sutures bites should be taken. So this is the for zigzag tear, anatomical landmark of prime importance, limbus, stellate edges, sharp angles should be taken care of so that it apposes well. And stellate as laceration as such like this is a nightmare for a surgeon, but we can suture it either by bridging sutures, pursing, everything which you have shown it here. But in my practical experience, I feel multiple interrupt sutures does a excellent job. So overall lacerations with iris prolapse, without iris prolapse, if it is coming less than 24 hours and is healthy, please repose it. You need not cut it, and if it is more than 24 hours or less than 24 hours, then you have two type of management. If it is more than 36 hours, then please cut it, and if it is less than 24 hours but no necrosis, no feathery margin, no maceration, no signs of infection, then please, then also you can cut it. This is a small video which says, which you have. So these videos, you can see the sclerocorneal tear. So first I have opposed the limbus, and then we start at the edge. So once this is done, and then you center you suture one, then you can go bisect it in equal half, and then finish this cornea first. Once cornea is fast, you can see here, now this is a tear which is gone beyond the iris insertion. So it will definitely bleed, you can see the bleeding, and so you have to suture. Once the scleral is opposed, then you can take care of this. SU wash and all at the end, because there is no cataract was there, so we didn't intervene for cataract. We need to aspirate the aspirate and then put a air bubble because the iris root is involved. So otherwise it will bleed and cause hyphema. So post-operative management starts with the topical antibiotics or antifungal depending upon the wound stature. You should look for the infiltrate or this thing. And topical steroid and medications can also be given, cycloplegics, and then subsequent posterior segment evaluation and management. Suture removal ideally at 3 months. All the sutures should be removed or broken sutures should be removed, and always tight sutures should be removed first, and then it should be correction should be given after that. So there are some controversies for management. They say whether open glove injuries with no PL should be touched or not. Definitely we should touch it. We should not go for a enucleation. We just do the reconstruction and have a close follow-up to see the early signs of sympathetic ophthalmia. And second is time. Time is also a little bit controversy, but still immediate repair is gold standard for all of us to obey. So then after this you need to go for a follow-up on counseling, prevention from similar trauma or protection of the other eye, and counseling in terms of vision outcome to the patient is of prior importance. So to conclude, principles of wound repair should be treated not as a strict rule but as guidelines. And there is no set guidelines which are comprehensive. It doesn't gives you a total offer. Depending upon the panorama or the wound which the patient has come with, you have to give a realistic outcome. Thank you for your kind attention.